Hello and welcome everybody. I'm just going to wait another minute just for some latecomers. Hello and welcome to the Academy for Health Equity seminar series. Thank you very much for joining us. It's lovely to see so many people. It's my great pleasure to introduce my colleague Louise Prendergast today. Louise is a sociologist. She's also a public health researcher here at Bangor University, part of the Public Health Collaborating Unit, and also part of the Wellbeing Economics and Value team at Public Health Wales. So thank you very much, Louise, for joining us. Louise's particular interest is in end-of-life care, so I'm very much looking forward to hear you talk about that today.
Hi, thanks, Lorelei. So I'll just share my slides now and get straight into it, if that's okay. Right, so I hope everyone can see these slides, all right? So I'll start. So in this webinar, I'm just going to share some information and findings from the literature that focuses on palliative and end-of-life care. In particular, I want to cover factors such as how socioeconomic deprivation and diagnosis can affect people's experiences and outcomes. So I'll discuss that when needs are not met, care can become reactive, and that by improving equitable access to timely palliative and end-of-life care may improve people's experiences and reduce avoidable crisis-driven care. Just an overview. So I will look at palliative end-of-life care, what it is and why it matters. So then just have a look at Wales and UK current and future projections of need. And then I'll go into inequalities, looking at poverty and socioeconomic deprivation and diagnoses. And then I'll have a look at some direct and indirect costs and then some recommendations that are made in the literature. On each slide, there'll be a reference to a key article or a report, and in some cases, a QR code that can take you directly to a report. And there are many sources of literature, there are many studies, there's lots of research ongoing. So if anybody would like to contact me after the webinar, I'd be more than happy to discuss anything covered or not covered and send any additional literature. So firstly, definitions. So palliative and end-of-life care is an approach that aims to improve the quality of life of patients and their families. For example, their chosen family or friends who are facing challenges associated with living with progressive life-shortening illness. So that's whether it's a physical, psychological, social or spiritual. And importantly, it's about supporting people to live as well as possible for as long as possible with dignity, comfort and a sense of control. And this can be at any stage of a life-limiting condition. Now, end-of-life care typically refers to care and support for people in their final months, weeks and days of life. And it also focuses on comfort, dignity, symptom control and support for families and those close to the person. So palliative care can be delivered through many services by a wide range of roles, including nurses, support workers, paramedics, care home teams, hospice staff, care agencies, social care, voluntary and third sector organisations. And this can be across different settings, including hospitals, care homes, hospices, people's homes, or even prisons. And people might move across these settings and encounter different teams. So in Wales, palliative and end-of-life care is delivered within an integrated health and social care system. If we look at the global picture, palliative care is recognised by the World Health Organization under the human right to health. So it should be provided through person-centred and integrated health services that pay special attention to the specific needs and preferences of individuals. However, globally, there's an estimated 56.8 million people including 25.7 million people in the last year of life who are in need of palliative care. Now, this global need for palliative care is predicted to increase due to ageing populations. According to the World Health Organization, serious health-related suffering is increasing. So nearly 73.5 million people experience serious health-related suffering annually, and about 80% living in low to middle income countries. Now, this increase is driven mostly by non-communicable disease, such as cancer, cardiovascular disease, and dementia. So globally, only about 14% of people who need palliative and end-of-life care receive it. And some of the barriers cited are regulations for morphine and other palliative medicines, and a lack of awareness among policymakers and health professionals, and misconceptions about palliative care, such as that it's only for patients with cancer or that it's just for the last weeks of life, as well as some cultural and social barriers. So looking at UK and Wales, the UK comes high up in a world comparison for quality of death and dying. However, also reflecting the global trends, deaths in England and Wales are projected to rise by 27% by 2040. So in England and Wales, the annual demand for palliative care is projected to rise from around 375 people to over 537,000 people per year by 2040. If we have a look at the rising demand for palliative and end-of-life care globally and in the UK, many people do not currently have the care and support they need. Nearly 1 in 3 people who die in the UK are without adequate support. So this is approximately 200,000 individuals annually. So in other words, many people experience unmet palliative care needs. So to have a proper understanding of what this was, what unmet palliative care needs are and how they're defined, researchers on a Marie Curie commissioned project held co-production workshops with people affected by life-limiting illness and health and care professionals. So they were asked in these co-production workshops to identify and rank what unmet need looked like. And this was the agreed definition. It was unmet palliative care needs are present when a person with a life-limiting illness has symptoms, psychosocial concerns, or care requirements that are not adequately addressed through available services, and with an inability to access or receive person-centred care. So this definition was then used to analyse the results of a nationally representative survey of 1,194 bereaved family carers to find out the number and the proportion of people with unmet palliative care needs. This is some of the findings. In the UK, the study found that 46% had unaddressed physical or psychosocial symptoms. 45% had a lack of adequate basic primary care at the end of life, and 31%, that's over 203,000 people, experienced both unaddressed symptoms and insufficient primary care. So without any interventions, there's a predicted increase of unmet need in the UK population by 2050. So this would be increases in unaddressed symptoms projected to rise by 21%, insufficient primary care increased by 25%, and total unmet palliative care needs, which is both of them, would increase by 21%. If we look at specifically Wales from the same data, the study found that 49% of people experience unmanaged physical or psychosocial distress. So 43% lack sufficient basic primary care across access at the end of life. And 29% faced unaddressed symptoms and insufficient primary care. And again, applying this to future rates, then adults with unmanaged symptoms will increase by 18%. Those facing inadequate primary care, 17%. And for people experiencing both, this is predicted to rise by 14%. So looking back at the current figures, in Wales, around 32,000 people require palliative and end-of-life care. 29% of adults in Wales have unmet palliative care needs, with over 10,000 people facing their final days with unaddressed symptoms and inadequate access to GP support. And if you look further at the data from England and Wales, researchers found that variations in levels of unmet need according to different populations. So they found that people who were 85 or older were less likely to have unmet needs than those in the 65 to 84 age range. But they also found that 25% of people who described themselves as living comfortably experienced unmet need, compared to 36% of people who described as just getting by or finding things difficult. This means that those who were finding things difficult or just getting by financially faced an increased risk of unmet palliative care need. So if we have a broader look at inequalities, we know that some people do not receive the care they need towards the end of life. So there are inequities in access to palliative care, and these are associated with socioeconomic, demographic, clinical, and geographic characteristics. So it's estimated that each year across the UK, 100,000 people die needing palliative care but not receiving it. People from lower socioeconomic groups, non-cancer diagnosis, and ethnic minority groups are less likely to access this high quality palliative care. Now, this is associated with a number of factors which are linked to unmet need. For example, referral failures. There's a lack of timely clinical referrals, and this can prevent eligible patients from entering specialised care pathways. Awareness gaps. So many vulnerable families remain entirely unaware of the relevant palliative services which are available to them. There's communication barriers. Vital health information is frequently unavailable in relevant languages, in accessible formats, or in culturally appropriate terms. Additionally, there can be institutional distrust, such as previous negative or discriminatory experiences when accessing mainstream care. And this can cause patients to avoid services, excuse me, until a crisis occurs. So the access and receipt of quality palliative and end-of-life care are particularly felt by those who've already encountered unfairness and discrimination throughout their lives, such as ethnic minorities face systemic exclusion, cultural sensitivity, and language barriers within standard healthcare. People with learning disabilities often suffered from a lack of tailored communication and an inability of systems to recognise their unique care requirements. And LGBTQ+ individuals can face heteronormative care assumptions, a lack of affirming spaces, and a fear of experiencing prejudice during their final days and throughout palliative care. Individuals in the lowest socioeconomic groups also face a high risk of end-of-life care symptoms going unaddressed. And this is what I'm going to talk through next. I'm going to look at socioeconomic deprivation and poverty. So if we look at socioeconomic deprivation, so this is the lack of financial resources and social capital that can limit access to essential needs such as adequate housing, education, employment, and health care. Health outcomes are shaped by social determinants across the life course, the social conditions in which people are born, which they grow, they live, they work, and they age, and this has a significant influence. So socioeconomic deprivation is an important driver of health inequity. People who are socioeconomically disadvantaged are more likely to live with a higher burden of disease, multimorbidity, and they may die younger. A person living in a more deprived area is less likely to receive hospice care, more likely to be admitted to hospital in the last 3 months of life, often as an emergency admission. They're less likely to access specialist palliative care and have greater use of acute services, such as high levels of emergency hospital admissions in the last 3 months of life. A recent report from the Health Foundation just earlier this year showed that healthy life expectancy in the UK dropped from 62.9 years to 60.7 years for males, and from 63.7 to 60.9 years for females. So people are expected to experience fewer years in good health after state pension age. Now, in Wales, women living in the most deprived areas had a healthy life expectancy of 53 years compared to 70.2 years for women living in the least deprived. This is a difference of 16.9 years. For men, the difference is slightly smaller at 13.4 years. And looking at a health inequalities 2040 report, it's estimated that the number of working age people experiencing major illness will increase from 3 million in 2019 to 3.7 million in 2040, with an 80% of this increase concentrated in the most deprived areas. We look at socioeconomic deprivation. We can look at a study that used, it's the English longitudinal study of aging. So this used data from England, and they found that people with less money were generally in poorer health. That poorer health leads to more hospital use. So the research used data from deceased participants of the English longitudinal study of aging, which is a representative sample of people in England aged 50 years or older. So they analysed the direct effect of wealth and education on death in hospital and 3 or more hospital admissions in the last 2 years of life. So from these findings, the author suggests that these findings challenge behavioural explanations for socioeconomic patterning in the use of hospital care towards the end of life. They suggest that health is a factor on the pathway between socioeconomic position and hospital admissions. And if we turn to Wales, more recently, research in Wales has looked at a population scale retrospective cohort study using the secure anonymised information linkage. That's a SAIL data bank, and that was using data from the 1st of January 2014 to the 31st of December 2023. So they looked at over 267,000 descendants. And this study found that those living in the more deprived areas in Wales experienced higher rates of emergency hospital admission in the last year of life, and they were less likely to be registered for palliative care. This means there is a greater reliance on acute hospital admissions rather than planned community-based support. So overall, they found that individuals on the palliative care register were discharged from emergency hospital settings at a faster rate and had a reduced expected length of stay, whereas those living in the most deprived areas and men and residents from urban areas and those living alone were unrepresented on the palliative care register. So if we look at poverty, we can see this is from the report Dying in Poverty in Wales 2025. This shows a comparison of UK and Wales figures of people dying in poverty in 2024. And this shows that being in the last year of life increases the risk of experiencing poverty for people of working age and pension age, although it's more acute for people who are working age. We can see Wales has the highest rates of poverty among working age people in the last 12 months of life at 32%. And this is an increase from 30% in 2023. 16% of pension age people in the last 12 months of life were in poverty, which was just a reduction of 1% in 2023. Excuse me, just need a drink of water. The poverty rates increased by an average of 6.5% for working age people in the last months of life. This study found that women of working age in the last 12 months of life are slightly more likely to be in poverty than men in the last 12 months of life, 29% compared to 28%. And that rates of poverty at the end of life are also much higher for ethnic minority groups. Fuel poverty was more prevalent for ethnic minority groups at the end of life, 26.7% in fuel poverty compared to 19.5% white people. So what do we know? We know that demand for community palliative care is rising, but access remains unequal. Inequalities persist, and these matter because they translate into avoidable suffering at the end of life. On the slide, there's a reference to a study that discusses the impact of poverty and deprivation. Now, this was a critical review from 2021 that highlighted how palliative care policy and service design was shaped around an imagined or an ideal patient who was envisaged to be securely housed, financially stable, and supported by the family. So they were the ideal patient in palliative care was typically assumed to be white, middle class, and male. And this paper discusses how policies and services are designed around people who can plan ahead, who can self-advocate, and who can navigate complex systems and often rely on unpaid family care. But when you look at some who are experiencing poverty, insecure housing, homelessness, or limited social support, a home death or advanced care planning or symptom control at home can become unrealistic or inaccessible. And the authors also state that those who are structurally marginalised are often labelled as non-engaging or hard to reach, rather than being recognised as being constrained by social and material realities. I'm going to take you through a study now, which was called Dying in the Margins, and this is by Richards et al. In 2024. This is a really interesting study because the authors focused on poverty at the end of life, and they used qualitative research because they wanted to seek the views and experiences of people who were living with both socioeconomic deprivation and serious advanced illness. So the researchers in this study used photo voice, which is where they gave camera to the people to record some of the, to take photograph of what was important to them. And they used professional documentary photography to focus on the barriers to and the experiences of dying for people experiencing poverty and deprivation in the UK. So this research was conducted between April 2021 and March 2023 with 8 participants who experienced serious advanced illness and family members. And they found that there were high costs of dying at home, and these costs were powerfully conveyed through images such as like focusing on the bed in the room and the heating thermostat set to low because of energy costs. But they also discuss how for many their environment inside and outside of the home, for some was oppressive and it was alienating with noise, cramped, poor social housing, crime, mold and damp, and a lack of access to an outside space. Nonetheless, the home environment was important for all participants as it was the space where their identity and their autonomy was continued, and some wanted to remain at home for as long as possible. However, there were high costs associated with remaining at home, such as for electricity, heating, equipment, taxis, and care costs. So being housebound and the costs of staying warm in the homes throughout the day incurred high costs. Also, there were high costs of washing clothes and bedding, for example, where there's soiling, vomiting, and general bodily fluids, which are associated with a illness, also added to electricity bills. And then in addition to that, you have the cost of taxis to and from medical appointments, to and from the hospice. And for those with no family or friends to care or advocate for them, they were entirely reliant on what was offered by the state, and also needing to find out what was available. Additionally, all costs are high when income from paid work stops, However, the participants in the study, they did get benefit from homemaking activities, from their home comforts and companionship, and this supported their identities into their dying phase. The study also showed that only one of the 8 participants, had reached retirement age by the end of their death. And the authors indicate that this supports the quantitative research that quantitative research that those who experience poverty across the life course die younger. I think it's important to talk about caregiving at the margins to discuss unpaid carers and the impacts of end-of-life caregiving, because we know that up to 762,000 people provide end-of-life care each year in the UK, and these can be family members, friends, or others providing care and support without payment, and they play a key role in providing support to individuals. They often have multiple responsibilities. But those who provide unpaid care are themselves at a greater risk of living in poverty than those who do not. And end-of-life carers face an even greater risk of poverty than any other unpaid carers. The UK Commission on Bereavement found 43% of bereaved adults experience financial difficulties because of their bereavement, often resulting from a drop in household income. The likelihood of a carer being in poverty increased by 47% after the death of the person being cared for, with household income falling during this period. So end-of-life caring can impact significantly on the carer's professional life. End-of-life carers of working age need to balance their responsibilities around caring and working. And Marie Curie's Better End-of-Life research found that many end-of-life carers struggle financially as a consequence of taking unpaid leave, changing jobs, taking annual sick leave, or leaving employment entirely to cope with the demands of caring. So I'm going to move on to a second factor, which is implicated in inequity in palliative and end-of-life care, and that is diagnosis. We know that people with a non-cancer diagnosis, people with non-cancer illnesses such as organ failure or progressive neurological conditions, can experience significantly higher poverty rates and reduced access to palliative and hospice care. Of the over 528,000 deaths in England and Wales in 2019, 71% were from non-cancer conditions and 28% were from cancer. A systematic review by Tobin identified persistent inequalities in hospice care access, with only of the 29,000 or so deaths in hospices, 84% were from those with cancer and only 15% for non-cancer. Another systematic review focused on primary care found that people with non-cancer conditions were less likely to be included on palliative care registers. And in one study, 78.8% of patients with chronic obstructive pulmonary disease or heart disease and 59% of patients with dementia were not included on the palliative care register when they died, which was compared to 38% of patients with cancer. So these inequities were attributed to non-cancer illness trajectories being less predictable than cancers, and sometimes the more predictable cancer dying trajectory facilitates an earlier recognition of the final phase of life, and for example, better suiting time-limited hospice care. Whereas more prognostic uncertainty for people with, say, chronic chest and heart disease, dementia, or frailty of old age can prevent timely end-of-life care discussions and planning. We'll just have a look at people living with dementia in terms of access to palliative and end-of-life care. So their access, palliative and end-of-life care for people living with dementia, remains inconsistent and inadequate, as many people experience unmanaged symptoms and over a quarter die in hospital despite evidence that most would prefer to die at home. A survey of carers and palliative and people living with dementia across the UK found that many families and people are missing out on timely, compassionate and coordinated palliative and end-of-life care. And there were gaps in early planning, there were gaps in conversations about future care needs, a lack of professional confidence and training, limited access to specialist dementia nurses, such as Admiral nurses, and again, an over-reliance on crisis-driven and hospital-based care. NHS England also report that the combined health and social care costs of dementia is higher than those of cancer and coronary heart disease because of the complexity of needs and the lengths of time people require support for. Many of these costs are due to hospital-based admission at the end of life. So therefore, research consistently suggests that proactive, coordinated, and more accessible palliative research in the community is needed. The impact of unmet palliative and end-of-life care needs is felt by family caregivers who will adjust to grief. If the ill relative or friend is cared for by palliative care service, this may reduce the risk of pathological bereavement. However, poor or absent pain management and communication gaps in end-of-life care can increase post-death distress for families. Higher rates of anxiety, depression, complicated griefs, and post-traumatic stress when symptoms, communication, or emotional support are inadequate. When palliative end-of-life care does not address spiritual, cultural, personal needs, both patients and families report diminished sense of closure and meaning. And poor bereavement outcomes can affect sleep, physical health, ability to work, and long-term quality of life. In addition, material deprivation means that a person is less likely to access therapy or be able to take time off work, and financial strain can compound existing financial stress and increases prolonged grief risk. In the UK alone, bereavement costs an estimated 23 billion annually, and these costs have been largely invisible in palliative care funding decisions, and bereavement outcomes are rarely included in economic evaluations. So talking of economic evaluations and costs, addressing inequities in palliative and end-of-life care could potentially enable earlier, more appropriate care, reduce avoidable hospital use, and deliver both better outcomes for patients and family, and give significant cost savings. So we can see here that most end-of-life spending in the UK is already concentrated in reactive hospital care. 2022 public expenditure on people in the last year of life was estimated to be at least £22 billion across the UK. This is over 33,000 per person in their final year of life, and only 11% of healthcare spending goes to community care and primary care combined. Statutory funding for independent hospices accounts for less than 4%, and these figures don't include costs borne by the individuals and families. If we look again, we can see the healthcare cost per descendant in the last year of life. By Clark looked at where adults receive care, and they calculated an estimate per descendant based on all adult deaths in the UK, that total healthcare costs per person were 19,000, rising to over 24,000 in 2024 adjusted terms. Again, acute hospital care dominated. So we know end-of-life care in the UK is heavily hospital-centric, cost-intensive, and the most of the spending is concentrated in acute settings. Much smaller proportions are directed to community care, primary care, and hospice services. So what can improve this? Well, research has shown that palliative and end-of-life care delivered through multidisciplinary teams with specialist palliative care integrated through specialist and generalist teams is effective, leading to improved outcomes for patients and their family caregivers. So these services are associated with reduced avoidable healthcare utilisation and cost savings, including reduced use of urgent and emergency care and reduced length of inpatient stays. So this is from a study by Peter May that discusses that shows economic modelling that home-based specialist care reduced healthcare costs by over 7,000 per person, while hospital-based specialist care reduced costs by over £6,000 per person. So some recommendations then. We know that late identification for palliative care is associated with higher emergency hospital admissions, increased healthcare costs and poorer experiences. So if we could have improved access to specialist palliative care, particularly early on, this could reduce avoidable crisis-driven care and give better individual outcomes and cost savings. There are significant inequities for individuals from low socioeconomic groups and those with a non-cancer diagnosis who are less likely to be identified early and access services. So addressing these is essential. We need to understand how and why people who might benefit from palliative care do not receive it, which might mean new approaches to identifying and engaging and meeting the needs of underserved groups, which could mean quantifying the cost of health and social care for palliative care needs, combining data with lived experiences to understand decision-making crisis and service gaps at the end of life. This could also mean exploring interventions that address these inequities, shining a light on those that do work and show how and where they add social value. Just finally, there is a dedicated palliative and end-of-life dashboard that has been developed with digital healthcare rails. And the aim of this dashboard is to support national ambition to reduce health inequalities and access to end-of-life care. And so from this dashboard, it's an aggregation of data on interaction with unscheduled care services. So through this data, you can see the nature of multiple service interactions per episode of care, including gaps of service access, and it can help identify possible inequities of care in the last year of life across Wales. It's already shown a better understanding of the extent of unscheduled care interactions and a high level of emergency day use in the last year, particularly the last 3 months of life, and the potential impact of specialist palliative care service referral. So this dashboard uses data that's already on people who are already deceased, so it's retrospective and it can inform studies that look at the impact of service development innovation over time. And patient-reported outcome measures will also be included, so that's good. So just to finish, people experiencing poverty and socioeconomic deprivation have greater unmet palliative care need. People with non-cancer diagnosis also experience reduced access and later identification. However, these groups often overlap, compounding disadvantage. Unmet need in palliative care is both an equity issue and a cost issue. So addressing inequities potentially improves outcomes for patients and families, whilst reducing avoidable high-cost hospital care. And more research is needed to better understand and address these inequities to improve outcomes, reduce costs, inform policy and inform practice. So I'm going to finish there.
Thank you very much, Louise. That was really interesting, comprehensive, and I was particularly taken with this idea of services being designed around an imagined patient who is housed and supported and resourced. I think that's something that, you know, it resonates throughout health policy more generally and health services more generally. So yes, thank you very much. We do have 5 minutes or 7 minutes actually for questions. If I think we're small enough, if you want to just put up your hand, we should be able to spot you. Or if we can't, maybe unmic and ask Louise your question, or put it into the chat. Nathan.
Thanks, Louise. Yeah, really interesting. I'm obviously we worked together on a project around paediatric palliative care, and I think one of the challenges that we came across was how difficult it was to measure the cost of palliative care because of the amount of variation that we see across, you know, the different experiences and the different conditions and so on. So I was just wondering if you had any thoughts on how going forwards health economists and people working in you know the finances of healthcare could find a better way or a more uniform way of measuring cost of palliative care.
Yeah, this is something that's been an issue. I know, I don't know if Shlinos is on the call. Shlinos, Spencer also did a rapid review of identifying costs of end-of-life and palliative care, which was really interesting, really informative, and there's some recommendations there. But I think also what this highlights is there's a lot of costs that aren't included. So a lot of these costs are underestimated. So we saw here, they've also got the costs of bereavement, which are significant. So this Sue Ryder estimated the billions of costs to the economy there. But you've also got the costs for the unpaid carers, again, which are significant, and the health and well-being of people and people at the end of life. So I think a more comprehensive research generally, because a lot of the research, we're looking at economic costs, but we just need to sort of look more, because whatever costs they are, they're definitely underestimated.
Thanks, Louise. And just as a follow-up as well, I think that one of the challenges we have is that with economic evaluation and health economics is very much focused on like quality outcomes and this idea of how you can improve someone's quantity and quality of life. But the reality is, for end-of-life care and palliative care, being able to make an economic case for additional investment is really difficult, because it doesn't fit in with some of the narratives we have around finances and healthcare systems and why we'd want to, where value comes from. So I just think it's really important work, and just to say that I think it's great that that you're highlighting some of the excellent work that's coming out of that space.
Thanks.
So we have one and maybe two questions coming up in the chat. So I think we'll probably have time to take those two questions before 1 o'clock. The first one is from Leah. She's wondering about medical assistance in dying, MAID, and if this has come up in your work and if you have any insights.
So I was looking at that previously, like looking at assisted dying, and that's really interesting, because on the one hand you've got the argument that it was choice and it should be pro-choice, but again some commentators said, well, this is almost like a sort of a middle class issue, that there are lots of assumptions made in medical assistance in dying, and then so there are lots of assumptions there. But on the other hand, people were saying, you had commentators saying, well, we can't have this because there isn't good palliative and end-of-life care already, and if there was, then this wouldn't be an issue. So there's a whole lot of stuff there, and a whole lot of interesting arguments on both sides. But one of them did say that there's not enough good palliative and end-of-life care, so people will feel like a burden, and there needs to be more investment in these services. And on the other hand, people were saying, well, it's my body, I want to have a choice. So there's a massive discussion around that, which I'd be really happy if anybody wanted to get contact with you about that. I could talk at length about both arguments, but it's not happened in the UK, but obviously medical assisted dying is in the US and other countries.
And we have a comment from Gwyn. Gwyn, I don't know if you want to unmic. So Gwyn's just commenting on in the importance of carers and informal support, and how, of course, not all families get on. Exactly. And how it's a really important protective factor, and the outcomes can be much worse, in those situations where you have family politics, but very difficult to quantify. Definitely, which is, I think, why there are more calls for qualitative research to go alongside the quantitative data that we're seeing coming out. Definitely a call for that. Thank you. And apologies, Gwyn, that we can't get your get your mic to work. So yes, I think Tracy's just put in some information in the chat. Thank you very much for joining us. This is the last seminar for this academic year. We're going to put together another interesting programme for you to start again in September. So I hope that you will join us again next year for these seminars. I mean, I know I really enjoy them. And they're always so fascinating. We've also got the Academy has also got some scholarships. Tracy, did you want to say something about the scholarships?
Yeah, just that. Keep an eye out on our LinkedIn page, because we will be advertising some scholarships for our flexible delivery modules on systems leadership and mental health and wellbeing. So if anybody's interested, please get in touch with us at the Academy, but also keep an eye on our social media platforms.
Okay. Thank you very much, Louise. Yes, I can see people clapping. So thank you very much. And thank you everyone for joining us. Please enjoy the lovely weather, enjoy the bank holiday, enjoy half term, and I hope to see you in the autumn.
Thank you.
Diolch. Tra.
Thanks. Yeah.
Thanks all. Bye.